I'm Roger Baker, Executive Director of the Stratfor Center for Applied Geopolitics at RANE, a global center of excellence for geopolitical intelligence and analysis. Learn how you can put geopolitics to work for your organization at ranenetwork.com.
Welcome to the Beyond COVID podcast from RANE Network. In this podcast series, David Lawrence, co-founder of RANE, speaks with Dr. Fred Southwick, an infectious disease specialist at the University of Florida's College of Medicine, and Dr. Bill Lang, an expert in public health responses to biological incidents, about the current state of the COVID-19 pandemic. Let's listen in on this week's conversation.
Fred and Bill, once again, thank you. Happy New Year. And appreciate your coming on. There's actually a fair amount to talk about, both in terms of the epidemiology of what's happening out there, not just with COVID, but respiratory issues. And Fred, maybe you'll basically drill down and talk about the new variant of this and how people should be thinking about this, and of course, what we should be doing. But Bill, maybe we'll start with you.
Sure. What I'll talk about a little bit is the epidemiology of it, and the reason I say that is because all over the news now is that COVID's coming back with a vengeance. So let me describe what that means. What we're seeing is that COVID death rates are up again, and as we know, unfortunately, death rates is one of the best ways to track COVID, but we're up to about 1,400 deaths a week, which sounds awful. But the typical flu deaths per week are somewhere on the order of 1,000 to 1,200. So we're not really that much higher than typical flu deaths. What this is doing is the people dying are the people who are typically at extremes of life, typically older, and that's where we're getting more deaths. This is additive to the typical flu deaths, though, so it's not like we want to ignore this. The other thing we are seeing is that, again, looking at the wastewater rates of concentration of viral loads in the wastewater, and those also are up again. Now, all that being said, the ER visits for COVID are down about half of what they were a year ago at this time. And deaths are down from last year. So what that's telling us is that, yes, COVID is up. The number of infections with COVID are back up again. We would expect that after the holidays, but they are not up at extreme levels. And very importantly, this COVID is behaving in terms of what it does to people, something similar to the flu. It's not this terrifying disease that it was 4 years ago. So it has changed, and our immunity as a human population has changed. So don't think of this as being the same as what we were dealing with 2 years ago. It's up, but if you're in an at-risk group, get vaccinated. Yes, and that's even me saying think about getting vaccinated again. If you're not in an at-risk group, I'm not as compelled to push people for vaccination, but it's something to keep an eye on.
Bill, that's a really excellent summary, and I agree with all of your statements. The JN.1 was of great concern about a month or 2 months ago when it was identified, because the number of mutations in this particular variant were almost as many as Delta versus Omicron. Now, the JN.1 is in the Omicron family, but it has roughly 30 amino acid differences. And what that means is that the routine immunity may not be as effective. In fact, it isn't as effective, and that's why we're seeing this rise in symptomatic cases. Now, the good news is it's still in the Omicron family and seems to be of lower virulence or less severe than Delta or the earlier variants and in the original virus. So, and the other good news is the booster that's available now is protective, shows significant protection against JN.1. Therefore, I recommend anyone who has underlying serious disease that would make them develop more severe complication from the virus, anyone over the age of 65 should get the booster. The younger people that are healthy, that's a little more of a gray zone. I personally favor them getting it too, but Bill and I differ on that one opinion, and that's fine.
But you know what else is important is that we are not seeing any significant drop-off in the effectiveness of the antivirals, Paxlovid. But what we are seeing is that the at-risk population, basically the population that Fred just outlined, over 65, or those with significant underlying medical issues, they're not getting Paxlovid. The utilization of Paxlovid has dropped off significantly from a year ago. And I think it's people have become a little bit complacent. And I think it's reasonable to be a little complacent if you're in a younger group. Yes, there are still young people who have severe illness or die of COVID, but not that many. But the people in the older group are also becoming complacent. They'll say, "Oh, I had COVID a year ago. I'm not worried about it. I didn't get real sick last time." But as Fred noted, this JN.1 is different. In most people, JN.1 is going to be just another, viral illness. But it's different enough and yet has enough similarities to the original COVID viruses that it can cause bad disease. So if you get COVID and you're in an at-risk group, get Paxlovid right away, assuming you don't have a contraindication. But you should be thinking about it.
Bill, I strongly agree with that. And one of the keys is there's a window of 5 days where it's really effective. So from the onset of symptoms, you have 5 days. So those that are at risk should not wait around to see if they're going to get better, but because by the time they get worse, the Paxlovid will not be very effective. But it's been shown to reduce hospitalizations in really all strains by 85 to 90%. So it really is a very effective drug, and the side effects have not been very significant. So I also strongly recommend that those at risk get Paxlovid within the first 2 to several days of symptoms.
Yeah, just a couple of quick notes on Paxlovid. I've written probably myself getting now close to 200 prescriptions. I've had probably five to 10 patients that may have had rebound from it. That seems to be a little bit below what the reported number is. The reported number is somewhere between 10 and 20%. But most of my patients I follow very closely, so I feel very comfortable with my numbers. And then also in terms of side effect, almost universally report the bad taste in your mouth, but that's about it. A little bit of diarrhea, but it is a very, very well tolerated medication. One other point, going back to vaccines for a minute, we've reported this in the past, but there's some more data coming out that the vaccine is associated with a lower incidence of long COVID. Now, the one caveat to that is that the overall reporting rate for long COVID is going down fairly significantly. It speaks to maybe that there was some degree of a psychological component to some, not all, some cases of long COVID, and that people were just afraid, and that's normal. You're afraid of the unknown, and any symptom is interpreted as being part of a reaction to COVID, and that's backed off a bit. But even controlling for that, the data looks pretty good that people who are fully vaccinated have a lower incidence of long COVID. I'm not fooling myself. We're not going to convince anybody at this point who hasn't had the vaccination to go get vaccinated. But still, it has been shown to help reduce the incidence of long COVID.
So let me jump in with a question that's coming from a variety of clients in our network, which is people are just not testing the way they were, and they may in fact have COVID and the symptoms, but because of the vaccines, these are tolerable rates. What's your advice about testing when you have certain symptoms? And obviously, there's a matter of your being contagious to others. There's also a matter of, getting Paxlovid, at an early stage, talking to your physician, etc. Thoughts on that issue?
So in my practice, anybody who is either at risk or is routinely around somebody at risk, I recommend to them that if they get symptoms that could be consistent with COVID, and at this point, symptoms that could be consistent with COVID are fever, sore throat, body aches and pains. It's kind of the typical viral syndrome symptoms. It's very hard to separate it out. But if you do get those symptoms and you are at risk or routinely expect to be exposed, I strongly urge those people to get tested, so they don't get sick themselves or transmit it to someone who may be ill. When you get below that, and you get younger people who are not not around grandparents, kind of thing, I'm not as I don't push as hard on getting tested every time you think you may have COVID. You're going to be testing yourself, all the time, because people's immunity has been down a bit because of having been masked and semi-isolating over the past few years. So people are getting colds, just general colds, at a higher rate than they would have in previous years. But I still think that if there's any reason why you think you might be at risk to yourself or others, you should get tested so that you can get treated, so that you can mask or avoid being around people who may be at risk.
Yeah, David, I completely agree. One group that's really a difficult problem are college students, or that are in crowded environments repeatedly. And the problem there, they're getting colds all the time. They need antigen testing so frequently, and what the benefit is really unclear. But if they're going to a family outing where they're elderly people or they're exposed to individuals that are immune compromised, I think in that situation, then they should test themselves.
Okay. You may hear it in my voice. I was visited over the New Year's by my two young grandchildren, 4 and 6. And I like to say they're not signatories to the Geneva Convention on Biological Warfare. And and sure enough, the day after they arrived, both with the symptoms, and the older one had, 101, 102 fever. When it didn't go away after 2 days, I brought him to the pediatricians, and I was hoping it was an ear infection, quick antibiotic. But she looks at him and asks him whether his ears hurt at all, and says no. And she quickly turns to me. She says, it's either COVID or influenza B. And I'm going to test for both. And what that highlighted to me, the symptoms very, very similar. We went through what he had been experiencing. And what I'm hearing as a takeaway from you guys is that to the extent that you are going to be in contact with at-risk individuals, whether family or broader, as a matter of, I'll call it civic responsibility, you should test to see whether you have it. And of course, what's complicating that, I don't believe the government is dispensing the test kits anymore the way they were, or the insurance companies for that matter.
No, I believe they are. I mean, unless this has changed in the last few weeks, you can request a test kit again.
You can still request, okay, because our local pharmacies here are no longer giving them out, just for what that may be worth here in the New York City area. Or at least they're not doing it in a willful way. Maybe you have to see the manager, Bill. But they looked at me as though I was asking for something quite antiquated. But in any event, something came out today. Apparently there was a hope that taking Paxlovid might be helpful in treating long-term COVID, however that ultimately gets defined. But apparently, at least initial studies indicate that it is not. Do you have any further thoughts? I know we've discussed long-term COVID and the efforts to actually understand it, define it, et cetera. But any thoughts how people should be thinking about the long-term effects of COVID?
So I think I don't have any new thoughts on the long-term effects of COVID. I kind of outlined a little bit that I think we're seeing less incidents of new cases of long COVID. I think that's a combination of people being, less terrified of COVID, and I think it's also because immunity, almost everybody in the community is now, at least to some degree, immune from COVID, either from vaccination or from having had COVID, and that includes people who did not clinically know they had COVID. Almost everybody has been exposed. So I think that even having a lower degree of immunity is going to significantly decrease the rate of long COVID. So it's not as big a concern in the community as it was a year, 18 months ago. And I did confirm that you can get COVID tests, free COVID tests, if you go to covidtests.gov. You can get up to 4 free COVID tests sent to you by the U.S. Postal Service.
Bill, I don't have anything to add to what you said. The problem remains the exact pathogenesis or mechanism by which people get long COVID is very poorly understood. We know these symptoms, but we really don't know the exact cause. And the suggestion is that it's a hyperimmune response. And we do know that certain individuals have more powerful immune reactions to all antigens. And it's likely that there is probably a genetic component to long COVID. So whether Paxlovid's going to be, it'd be very hard for Paxlovid to show a benefit. As Bill said, most people are already immune, so the concentration of virus in their body will tend to be lower. And then Paxlovid, you'll shorten the viral phase by a couple of days. So it's hard to expect, I wouldn't expect Paxlovid, given already the herd immunity, to be a benefit.
Fred, I know you've been dealing with some headline issues in Florida. Maybe be worth spending a few minutes for the audience on what's going out in the media world. And again, among the lessons we've learned during the pandemic is that there's no shortage of information, just a shortage of information that people can rely upon and trust. But maybe you can share with the audience sort of the headline issues in Florida.
Yes, 2 days ago, our Surgeon General, Dr. Ladapo, published a position saying that he did not recommend the mRNA COVID-19 vaccines for anyone in Florida. And this was based on a finding that there are minor amounts of DNA contamination in the mRNA virus of viral vaccines. However, he did not put this into context. His statement was, well, this DNA could be incorporated into the host DNA, and therefore patients would be at risk for developing cancers. However, he neglected to point out that there's been tremendous amount of research in this very area, because we are giving DNA to people for gene therapy for those that have defective proteins to actually generate the deficient proteins. And so this has been a great concern for years. It turns out there's virtually no risk of that, because our bodies have an agent called DNase. And DNase, it actually breaks down loose DNA and destroys it. So this is he's created a straw horse, and again created it's really sharing disinformation, in my view, and further harming the reputation of this particular vaccine. As I pointed out, I was in a press conference about this. The developers of the mRNA vaccine received the Nobel Prize because scientists throughout the world recognized what a major and exciting advance this is. And so for someone who with a limited research and scientific background to question the vaccine in this way is really shocking and disappointing. And we would hope that we can stop this kind of communication in the future because it's, again, undermining the CDC, undermining the FDA, and all of the experts, the hundreds and hundreds of vaccine experts who have come down in favor of this vaccine.
And Fred, I think you've commented in the past, maybe it's worth reiterating, how closely followed this vaccine is by leading experts around the world. Maybe you can elaborate on that a bit for the audience.
Yeah, well, because of the political, for reasons that are still complicated, the vaccine has become a political issue when science should not be political. Science, as we mentioned before, is about seeking the truth, using the scientific method. And that is a very neutral approach where you test your hypothesis. If the data is consistent with it, you keep the hypothesis. If the data is inconsistent, then you move on to another hypothesis. This is about seeking the truth. And hundreds of experts in the vaccine field, hundreds of experts in gene therapy and use of mRNA and DNA, all have strongly supported this vaccine. And so the only people that have been criticizing it tend to be on the fringe of science, and they do not have scientific evidence to support their hypotheses. What they often do is they find a flawed study, and unfortunately scientists aren't perfect. They find one study in not very good journals where the scientific method was not rigorous and where they come out with a contrary result. And that does happen in science, but the overwhelming body of evidence supports the safety and effectiveness of this vaccine, supported by a Nobel Prize.
And as people who have been listening to this series over this whole period know, I've been a little bit, I don't want to say skeptical of the vaccine, but I've been a little bit more questioning of the vaccine throughout the whole period. However, on this one, I agree completely with Fred that there is no good evidence that finding a very small degree of DNA contamination is going to have any effect on this vaccine. This vaccine, I've taken it myself. I've ensured my family takes the vaccine. I believe the vaccine has done amazing things for putting a lid on this epidemic. I think that people should not be afraid of this vaccine. Once you've been fully vaccinated, I don't know how many times you need to get additional vaccines. We can disagree on that a little bit, but I think this is a safe, well-studied, and effective vaccine.
And I'd like to remind the audience what Bill, you and Fred have reiterated. The purpose of this is not, and the efficacy of these vaccines should not be measured about in terms of whether people get COVID, but the impact on them if they do. And this is about reducing hospitalizations and obviously deaths. And Fred, as you mentioned again today, different populations are at different degrees of risk. And Bill's advice to his patients correlates with, who the patients are, their age, medical history, I'm sure the interactions and demographics of where they live and how they interact with family members. I'm going to go back because, Bill, you have to endure me on this testing issue as a lawyer, not as a doctor. But I did a little bit of additional research because we had so many questions from clients who claimed that, these test kits were no longer readily available. They wanted to roll them out more broadly. Apparently, the government did disband the distribution, reinstituted it in October of 2023. but it appears that you only get 4 per household from the government. There are obviously sites that will test for you, but it does not look as though as many are being dispensed free of charge through various government agencies. So what we'll do for the audience is we'll update this to get a complete view of this. And you're right, the USPS, United States Postal Service, does distribute it, but basically it's 4 per household. And I don't know about you guys, but during flu season, we tend to test a lot. And if you have, even adult children, grandchildren, and things like that, 4 tests only go so far.
Let me make, if I can make one
please.
more comment on testing.
Yeah.
And this has actually come up clinically in the last couple of weeks. People say to me, well, if I should test for COVID, shouldn't I be testing for flu also? Because those are the two
Right.
viral illnesses that you can readily test for and treat for. And it's hard to say if yes, you should test for COVID and not test for flu. Flu test, there is no home flu test, however. If you want to get a flu test, you've got to go to your doctor or go to a clinic and get tested. We think that may change next year. This has been a long-standing issue. Whether it's doctors just trying to lobby to drive people to go to the clinics, that's me being a little bit cynical. But I think what we've proven is that people can effectively and efficaciously do testing themselves and then contact appropriate prescribers to get treatment when needed. So for this year, if you think you've got something, it's not a bad idea to go into your local care provider and get tested for both flu and COVID, and then treat if one of those is positive.
In the closing few minutes that we have, Bill, Fred, looking out into the future, what should people be looking for, looking at, both in terms of protecting themselves, their organizations, and also just in terms of reliable sources of information?
Well, I think the sources of information are the same as they have been. The rigorous scientific journals, Science, Nature, New England Journal, JAMA among them, are all good resources, as is the CDC website is very effective. And the FDA, and also renowned universities, medical centers. There, the information is accurate as well. And you want to stick with where the true expertise is and where the truth always rules. I think that's very important. Avoid sources where there is some question about the expertise and background of the individuals. And as far as what's going to happen in the future, I think we're probably, because of the holidays and people gathering, and Bill can discuss this in more detail, we're probably in the peak because of the heavy exposure and large numbers of large gatherings. And now from here on in, there won't be any large gatherings, and we will move into spring and summer when people will be outside. So I think this should be the peak for the year, unless there's some new variant that comes along that is even more. I can't imagine there's going to be one more infectious than the JN.1, but it's always possible. But unless there's some very unusual variant.
So Fred, we are in fact at the current peak. We're right at about the same level that we were in 2019, right before we recognized that COVID was going to take off. Interestingly, the overarching influenza-like illness rate dropped, but it dropped because people started staying home. But we are at a peak. I think we probably will see. We may go up a little bit more, but we're probably at a fairly high peak right now. That's one thing that people should keep in mind, though, is that this is flu season, and as we see, even though people aren't as afraid of COVID, that people should be thinking about, businesses should be thinking about taking the reasonable measures that we took even before 2019 when we had a high rate of flu-like illness. Tell your housekeeping staffs to wipe down the high-touch surfaces again. If someone does have illness, any kind of respiratory illness, stay home. Don't come into work and infect everybody else. Those simple things that can be done. Increasing the air turnover rate so that you have less airborne infectious particles can be very helpful. So many of the things that we learned over COVID, we shouldn't stop applying them just because COVID is gone. Or COVID is not as scary as it was, not that it's gone. We still need to maintain vigilance against especially respiratory infectious disease. And going back to David's previous question, I think in addition to monitoring those sources, I think it's important that large organizations, and this is something I've said before, I think it's very important that large organizations have a source of good medical advice. All those sources that are out there, we're not going to expect the safety and security managers at large companies to go and be reading those things. They need that, just like they're going to have a safety advisor, a security advisor, or a legal advisor. I think that it's important to have a health advisor who can tell them what's going on and help interpret how that applies to their organization.
So great advice. As I look out, if I can just add one other thing, obviously you've focused on the medical. It's going to be interesting to see what emerges from hearings that are now scheduled involving Dr. Fauci and the connection with the Wuhan lab and other things. So Fred, I expect no shortage of interesting information and commentary and conspiracy theories and other things to come out. Well, hopefully it will be a search, for the truth, but it's in Washington, so I have no doubt it'll be highly political. And I'm sure we'll have some questions for you guys the next time out, but, we'll avoid the political hornet's nest. But it is interesting to me that this issue still has legs, and we have a congressional hearing coming up. So in any event, looking at that as well. Fred, in the meantime, hopefully the headlines will be better in Florida for you.
Thank you, David. Have a
All
good
right,
weekend.
and we're going to do a podcast with Fred's book in 2024 very shortly, Playing with Bees, which is done very, very well, and is an overarching series of lessons about how to improve the healthcare system in the United States. So congratulations on the book.
Right.
And
Thank
Bill,
you, David.
I've heard from independently from a number of organizations where you've continued to be of great help. A very calm and informed hand has been terrifically helpful to them. So I look forward to reconvening maybe in a few weeks. So thank you, guys.
Thank you, David.
Thank you.
This is the RANE Insights podcast, which is part of the RANE Insights series, comprised of both virtual and real-world events, offering unique practical perspectives from RANE's leading experts in risk management. To learn more, please visit us at ranenetwork.com. That's RANE network.com. Thank you for listening.